Hello, and thank you for viewing my virtual research presentation for the Massachusetts Pulmonary Section Annual Meeting. My name is Anthony Esposito, and I'm a research fellow at Brigham and Women's Hospital. As a member of the Interstitial Lung Disease Center, I have an interest in early detection of subclinical disease, with a particular focus in the inflammatory ILDs. I am therefore grateful to have the opportunity to share with you my group's findings of subclinical parenchymal lung disease in a rheumatoid arthritis cohort. This obviously is not a one-man operation, so I have to thank some of my co-authors who are listed here. In particular, I'd like to thank Dr. Tracy Doyle, who's my research mentor, who's guided me through this project. Many of you are likely familiar with the pulmonary manifestations of rheumatoid arthritis, of which you know there are many. But I would first like to provide you with a framework to assess the implications of our work. Pulmonary disease is a common extra-articular manifestation of RA associated with increased mortality and morbidity. It accounts for 10 to 20% of all mortality and is second only to cardiovascular disease. Of these, ILD is thought to be the most common pulmonary manifestation of RA that increases risk of death threefold. Subclinical disease has been identified in up to 2/3 of those with RA, 34 to 57% of whom have radiographic progression after 2 years of follow-up. COPD, broadly defined in RA studies to include asthma, bronchiectasis, and other bronchiolar disorders, other than just the typical emphysema and chronic bronchitis, is more common in RA patients compared to the general population. Patients with RA and COPD have a higher risk of hospitalization and a 10-year mortality of about 60%, as illustrated in this Kaplan-Meier curve by Hildegard in 2018. As you can see, the separation between the RA patients with COPD versus a matched RA cohort is greater, is more in the patients with COPD, that at 10 years is about 60%. To address the need for early detection of subclinical parenchymal lung disease, our prospective study was designed to screen RA patients for subclinical ILD and other parenchymal abnormalities, and then to assess other associated clinical characteristics and functional decrements. Our study prospectively enrolled subjects with RA and no history of ILD from the existing Brigham and Women's Hospital Rheumatoid Arthritis Sequential Study, otherwise known as BRASS. In total, we had 109 patients that completed the first study visit. Of these patients, 3 patients were excluded from the analysis because they had a history of emphysema or COPD that was either patient-reported or from a physician record. Then we had 106 patients for our analysis. These patients underwent a comprehensive assessment, which included a history and physical exam by a trained physician, self-administered respiratory questionnaires, full pulmonary function testing, blood sampling for serologies and routine labs, as well as high-resolution CT of the chest. These HRCTs were then evaluated by radiologists for subclinical emphysema and ILD using scoring systems that were previously validated. Other pulmonary abnormalities were also noted and including in our analysis. Overall, we identified 38 subjects with subclinical emphysema, which represented 36% of our cohort, and 16 subjects, or 15% of our cohort, with subclinical ILD. As I mentioned, overall, we found when we looked at both functional and imaging abnormalities, about 74% of patients had either of those abnormalities, as shown in this pie chart. I will mention that in this pie chart, this is not percentages, this is actually number of subjects. And so when I mentioned 74% of subjects had imaging or functional abnormalities, it is the total over the, it is the number over the total of 106. 69 of 106, or 65% of our cohort, had imaging abnormalities, which was broken down by subgroups in this bar chart. Subclinical emphysema was the most common, followed by pulmonary nodules, bronchiectasis, and subclinical ILD. Our main focus of this analysis was on subclinical emphysema and ILD. Emphysema occurred in 38 of 106 subjects, or 36%, and subclinical ILD occurred in 16, or 15% of subjects. 6 subjects had evidence of both. We then looked at the clinical and functional characteristics of patients who had subclinical emphysema as well as subclinical ILD, as shown in these 2 tables. On the left, I have pointed out subclinical emphysema. Subjects with emphysema were significantly older than patients who did not have emphysema, and they had a median Goddard score of 8 with a range of 4 to 12, which is in the moderate range. They did not have a significantly different smoking history, but interestingly, over almost a third of never smokers had subclinical emphysema, which has never been reported for in the literature. Functionally, these subjects had, with subclinical emphysema, had a diffusion defect and a trend towards a lower percent DLCO, and they also were more likely to have comorbid bronchiectasis. When we looked at RA characteristics, when we looked at their serologies as well as the duration of RA, we found that patients with a higher CCP titer had subclinical emphysema on their CT compared to those who did not. When we looked at subclinical ILD, the 16 subjects did not have differences in demographics, RA characteristics, or pulmonary characteristics to assist with their identification, suggesting that HRCT may be the current only available method to screen for this disease. We conclude that undiagnosed parenchymal lung disease is highly prevalent in the RA population. Illustrated here are representative images of subclinical emphysema and ILD. On the top, we have someone with mild subclinical emphysema, someone with severe subclinical emphysema. Believe it or not, this patient was actually asymptomatic and found on screening. We have someone with subpleural reticulations found to have subclinical ILD, as well as patients who had some ground glass and subpleural reticulations and D in this panel here. Of the diseases that we've identified, undiagnosed emphysema was the most prevalent, even amongst never smokers. Our data suggests that emphysema may be the most common pulmonary manifestation of RA, whereas in the literature, ILD is currently the most common pulmonary manifestation for these patients. As we have shown, subclinical disease, particularly subclinical ILD, may not be identified by different parameters such as clinical, laboratory, or functional evaluation. Therefore, we propose that HRCT may be the only screening modality to currently detect the spectrum of the disease in RA patients. That's all I have for you today. Thank you for your time and attention. Should you have any questions, please do not hesitate to contact me via the email address that I provided here. Have a nice day, and I hope you enjoy the meeting.